Hi, I'm Dr. Donald Jurovich, and today we're going to have a short presentation on the geriatric 4Ms category of mind. This presentation is part of our Dakota Geriatrics Workforce Enhancement Program and is intended to improve older adult health care. So the goals today are to use rapid assessment tools for detecting cognitive and behavioral changes in older adults. We want to manage both screen negative with preventive strategies, and we would like to manage screen positive patients with evidence-based interventions that include both non-pharmacologic and pharmacologic therapies. So one might ask why to go through the 4Ms with each clinical encounter. The advantages is that it provides a clinical tickler for the provider, the healthcare provider, about prevention if the rapid screen is negative. It also engages the patient for better planning in the final phase of their life. And certainly it'll help update what matters when circumstances change. And finally, we always look for the moment in patient care when it makes sense to transition from curative to palliative care. So I'd like to introduce a case study around the 4Ms. This is a 67-year-old lady who has hypertension, diabetes, hyperlipidemia, coronary artery disease, and she was brought to the emergency room by her daughter for nausea, confusion, fatigue, loss of appetite. The patient has felt sad since her sister's passing away a month and a half ago. She was prescribed fluoxetine by her primary care physician a couple of weeks ago. On exam, she was lethargic, she was disoriented, had slow speech, and of all the lab tests, she had hyponatremia. So the question here, given this cognitive change and certainly how she presented, should the SSRI have been prescribed? And I think the answer would be, and we should be in agreement with this, that the patient was manifesting grief with her initial encounter with her primary care, and that this is perhaps complicated grief that may have resulted in vegetative symptoms, and it may not have really met the criterion for a major depression disorder. So we have a iatrogenic event of hyponatremia caused by an SSRI that may not necessarily have been the first choice in order. So we want to talk about the vulnerability of older adults to our therapies, as well as trying to get an accurate an assessment of what their behavioral or cognitive changes might be due to. So that's where the recurrent screening of the mind or mentation is so important. So one of the compelling reasons for routinely screening for cognition and behavioral problems in older adults is that depression, dementia, and delirium all increase with increasing age. So we can see here just at a glance that depression affects 1 out of 15 people over the age of 65. And you can see dementia just marches upward, so that 1 out of 4 or 1 out of 3 even patients 90 and older will have some form of dementia. So it's quite prevalent. Another question about why screening. Some of this has to do with atypical presentations. It's certainly the case of a university professor who is able to answer all the questions on screening tests, but may have still underlying dementia. And so how would you recognize that individual who has problems with executive function? The other reason that we want to screen is that once identified, we know that these individuals have increased use of health services. There's excess disability, poor functional outcomes, and increased mortality when untreated. So we know these as the big ticket items, the 3Ds you may have heard about, depression, dementia, and delirium. However, I just wanted to mention that we need to also consider in our lexicon of behavioral and cognitive changes with old age, issues about anxiety. And actually, if on the internal medicine boards, they might ask about what's more prevalent, anxiety or depression in older adults, and the right answer would be anxiety. But as our case report illustrated, that there is a lot of issues about grief and perhaps unresolved grief that need to be of concern to us. And then also PTSD, particularly in the older adult refugee population. Loneliness and social isolation need to be on our radar, and then also substance abuse. And I'll just point out under substance abuse, not that we're going to talk about that at this presentation, but recently retired older women tend to be the highest risk for alcohol abuse amongst the populations. So part of the goals of addressing mentation is that we would like to delay cognitive decline over time. And in terms of depression, we want to cure it, and it is a very curable condition. And then ultimately, we're always on the lookout for trying to prevent the 3Ds. And so when somebody mentions that they are taking Tylenol PM at bedtime, an alert provider will say, well, that predisposes you to delirium because of the anticholinergic diphenhydramine. And so you would discourage the older adult from taking a medication that might predispose them to high cholinergic burden and future delirium episodes if they get sick. So what about the screening for the 3Ds? So as I mentioned, it can be educational for the patient, and it can prep the older adult for overall brain health, which often gets overlooked in the clinical setting. So to summarize, we consider using rapid screens for depression, dementia, and delirium, with the latter, delirium, being more appropriate in the acute care setting. Because only 1% of delirium is manifest in the ambulatory care setting. And we want to segue to our negative evaluations to primary prevention. So in that case, depression would mean identifying social engagement plans with the patient. In terms of dementia, the evidence-based interventions are blood pressure control, exercise, and cognitive games. With nutrition soon to become one of those other elements. In delirium, I gave the example of avoiding anticholinergics. And then for those who screen positive in any of the 3Ds, that we then go to a secondary assessment for staging and tracking progression. So for example, you will go from a mini-cog screen. If that's positive, then you go to the St. Louis University Mental Status Exam, or SLUMS, to stage the memory loss. And then most importantly, when you do screen for these 4Ms, that you create a management plan for each of the elements, so that there is a management plan or recommendation for either depression, or if they are not depressed, that you encourage socialization as part of the action plan. So thank you for your attention.